and go on to the next session, which is by Dr. Sishir Gang. And should it be steroid-free transplantation or free में steroid देने का transplantation? I don't know what he will be talking on, but let's hear.
Thank you, Dr. Khanna, for inviting, and also the Mumbai Kidney Foundation for this meeting. So the task given to me was to talk about, is it time to reflect again and think whether we should do a steroid-free transplantation, to do or not to do. So this also prompted me, because at the outset, I must say that we do not do steroid-free transplants. So, but then they asked me about it, it prompted me to think about it and then learn from you whether to move to this area or not. So the advantage of steroid are it is effective, as you all know, both for the treatment and for prevention of infection. It is cheap, not overly dependent on TAC and MMF, so you can actually reduce one or the other much more freely. During infection, one can safely withdraw MMF and are not left with a single drug, so it provides you that safety net to use that. So these are some of the advantages. Of course, benefits are countered by some of the side effects: loss of cortical bone, new onset diabetes, the worsening of the existing diabetes, wound healing, lipid abnormalities, hypertension, weight gain, cataracts, and especially growth retardation in children. But we'll not be talking about children because that would be a separate topic by itself. So there are two strategies. One is to do a complete withdrawal about 3 to 6 months or late after a year. Another is complete avoidance. No steroid or stopping within the first week of transplantation. So I thought, let me go back to the Cochrane review. What does it tell us about that to do a steroid withdrawal or not? And if you see, importantly, is if you do a steroid withdrawal, if the rejection rates are higher, the relative risk is about 1.77. And the other thing about NODAT is not really very great, and about other things are really the same, the graft loss and the mortality. So yes, you can do steroid withdrawal, but a price is that the rejection rates are higher. What about steroid avoidance? Again, in the avoidance, the rejection rates are slightly higher. The NODAT is slightly lower, but the confidence intervals are wide, so not necessarily that it is good, and the evidence is very, very low. So there is some price for it, but otherwise, yes, the mortality and the graft loss are nearly similar, whether you use steroid or not use steroid, with the suggested protocols and different strategies. So coming back to one of the most landmark papers, which actually made everybody think to do steroid-free transplantation, was this coming from the Steve Woodall's paper. And they did a prospective randomized double-blind placebo-controlled multicentric trial early, that is 7 days corticosteroid cessation versus long-term low-dose corticosteroid therapy, which is the current favored therapy. There are 386 patients, which they divided into two groups. And they concluded that one could do these type of transplants. And there was a similar slightly increased rejection rates, but a similar long-term outcome. Of course, some of the risk factors for cardiovascular disease like triglycerides were lower. NODAT requiring insulin was low, but NODAT overall was no different. And so one could do, and the weight gain was slightly lower. But if you look into the paper very carefully, it shows that if you use Simulect, that is the IL-2 receptor blocker, the rejection rates are much higher compared to if you use thymoglobulin. So thymoglobulin becomes mandatory if you have to do steroid-free transplants. Again, when you do a steroid-free, the WBC counts go lower because corticosteroids try to maintain the counts a little higher. So if you're using MMF, you need to dose the MMF a little lower or to check it more frequently and do that. Again, the important thing is we are all worried about the bone health of the patient. This is a 5-year-long trial, and they did not find any difference in the avascular necrosis, fractures, or anything about the bone health. So bone health, at least in the clinical sense, does not really change much whether you use low-dose steroid or not, at least in the trial based on this. NODAT, as I said, was similar, but only the need for intervals was lower. What about the Indian experience? The Indian experience, we have got two studies, one coming from Dr. Khair's group, and they did an early corticosteroid withdrawal, given a living donor kidney transplantation. It was a retrospective study. The induction used was basiliximab, tacrolimus, and mycophenolate with and without steroids. The rejection rates were higher in the corticosteroid withdrawal group compared to those who were in the corticosteroids. Significant difference was seen. Here, as you see, the rejection-free period. And as you know, some of them, of course, they were 1A and one or two were much higher grades also. What about the advantages in terms of the NODAT? There was no real difference. Of course, the numbers are really small. This is 33 because they took off the patients who had pre-transplant diabetes. So they are 3 out of 33 in the corticosteroid group and 2 out of 54 in the corticosteroid withdrawal group. Infections and number of antihypertensives, leukopenia, statin use was no really different. And a sentinel label had to be switched to the corticosteroid because of various reasons, either because of rejections or because they were not able to tolerate, or they felt that the counts were not coming up, and other reasons they switched. Another study which comes from, we have the chairperson here with us, Dr. Pathak's group. They, again, was a retrospective study, which is, they use low-dose rituximab and thymoglobulin induction with steroid for maintenance immunosuppression with protocol biopsies to improve long-term, study the long-term patient and graft survival. And this was more than 1,100 patients from a single center. So as I said, they used thymoglobulin, rituximab, and TAC and MMF, and prednisolone discontinues on post-operative day 5. They did protocol biopsies. Biopsy-prone rejections were 12.7% of the recipients, really very, very low, and 3.5% subclinical. The 1, 5, and 12-year graft survival, patient survival was 97%, 94, and 92, and the corresponding graft survival was 97, 90, and 86. So 86% of patients in their group survived more than 12 years. However, about 70% of patients remained on the steroid-free protocol at 12 years. So 30% who had to go back to steroids, of course, some because of rejection, and others because they had to switch from MMF because they were not tolerating MMF, they had to switch to azathioprine. So they decided to add in steroids, and some because they could not go down. They had to make some switches, and therefore about 30% of the patients got back to the steroids at about 12 months. But this was a retrospective study. There was no comparator group available with them. So I said that we must look at the very recent studies because a lot of the Cochrane reviews were done later. And this is one of the very, very recent study which has come up in 2021 in the KI reports. Now, this is a study from the Scandinavian countries, a randomized control trial on the safety of steroid avoidance in immunologically low-risk kidney transplant recipients. Generally, people who are choosing steroid-free transplants tend to choose a low-risk category because obviously we don't want any rejection. So this is a Sailor study. It's a 2-year multicentric open-label trial. They are immunological low risk and non-diabetic. So they excluded all the diabetic patients and they used the steroid avoidance. And the protocol was steroid avoidance protocol. That is, they used only for a very short period of 1 week and stopped it. It includes TAC, MMF, and ATG induction. And in the steroid maintenance group, they use tacrolimus, MMS, prednisolone, and basiliximab. So there are actually 2 changes that here they have steroid and basiliximab. Here they do not have steroid, but ATG induction. The incidence of post-transplant diabetes mellitus was nearly similar. There was no difference. Biopsy-prone rejections were similar. Composite outcomes were nearly similar. Kidney function was similar. And subjects to adverse events were nearly similar. So they did achieve a similar outcomes. But as I said, the dosage that they used was this. And a significant proportion of patients with steroid avoidance, and almost 36% within 2 years, had to be started on steroid for one reason or the other, which I mentioned earlier. So one could do a steroid-free transplantation, but the key question is, what are we trying to achieve now that we have protocols where we're using very, very low maintenance steroids and people are coming down very, very fast on it. So really the question in several of the editorials, even in this paper's editorial, they've argued that what is it our goal that we want to do? We are not getting any difference in the post-transplant diabetes because tacrolimus dosing causes diabetes. Bone health, as I said, doesn't really much different. And all the other parameters like hypertension or maybe cataract is one thing which comes on later on. Maybe that is one different. It's not available in this data because it are short-term studies. So, and many of them have to come back to it. Another important thing is that there's the papers to show that what happens in patients who have previous glomerulonephritis. And if you use a steroid-free product, one of the hazards of getting a recurrent glomerulonephritis is rapid discontinuation of steroids. So if we're using a steroid-free protocol, especially in patients who have a previous glomerulonephritis and are highly likely to recur, they are more likely to recur if steroids have been taken off. So it's important that at least this group of patients, you should avoid doing steroid-free transplants. And what is the trend, at least in the US RDS, we do not have data from many other places, but because this is the best data available, if you see from 2004, there was a very rapid interest because of the availability of tacrolimus and MMF and ATG. People thought that we have now got a situation where you can go off the steroids. So there was a rapid interest, about 30%. By 2008, the centers were doing steroid-free transplant, but since then it has plateaued out to 2014. And if you still in the this recent OPTN data, again, only about 30% of the patients are on a steroid-free, that is TAC and MMF, and about 70% of patients are still on TAC, MMF, and steroids. Saying that if there was some, so there are probably group of people who believe that it is a good thing and a group which does not believe, and one is not really able to convert the other, and therefore this data is remaining static. At the end, low-dose corticosteroid is safe, cheap, effective immunosuppression in all types of transplants. If considering a steroid-free, choose a low-risk, ABO-compatible, non-sensitized. There should be no delayed graft function. I did not show data, but there's enough data to show that in delayed graft function patients, the steroid withdrawal should not be done because they tend to get a problem. ATG induction is mandatory, and you need to keep modifying the MMF dose to avoid any leukopenia or which would occur, and you might have to sometimes dose it accordingly. So I would now leave it to all of you to think that my own take is to still continue with a low dose steroid in the maintenance group.
Thank you, Shishir. We have Dr. Pathak here who's got a good experience of steroid free, and then the other chairpersons could give in their comment before we open up for discussion.
My current number is
1,900.
Can you hold it properly?
hello.
Yeah.
My current number is nearly 1,900. When I started steroid free in July 2005, and I look at the first 57 patients till December 2005, 48 out of 57, that is 84% are alive today with normal graft function. The advantage over when I give steroids, the multiple reasons are because I do protocol biopsies. If I see IFTA, I give it. Recurrent IgA, I treat and then I continue low dose. Nowadays, I am not giving even with azathioprine. I'm making steroid free if I have somebody has MF diarrhea. But previously with MMF diarrhea, and I changed to azathioprine, I was using it. Initial stages, I did not give steroids after acute rejection also, but more because of literature, I started giving, though I did not find any benefit of that. Initially, I got away with the steroid free in rejection patients also. IFTA patients, recurrent IgA. So I started using steroids sometimes 6, 8 years, 9 years, 10th year, 11th year of transplant. First year is more than 90% remain steroid free at the end of 1 year. You don't see any cataract. You don't see any bone fractures. And I believe me, even 2.5 and 3.5 cause infections. Zero steroid looks like normal population. And the steroid free, that advantage is they require less MMF or half the dose. They require less tacrolimus. They don't get much infections. They just come to the hospital for routine checkup. And face remains normal. I have done the BMD studies at 3 months, at 1 year, 5 years, and 10 years. Bone does not worsen, which worsens in avian country with less dose steroids. So benefits for to me, growth retardation in children is not there. I have got children growing up more than 1 foot. Obvious advantage children, no cataracts. First time, the person who drew my attention to steroid free was my ophthalmologist, who said, you are not referring any patients to me. And diabetes, obviously, it was almost 20. When I was first using steroids in the country along with tacrolimus in 2002, diabetes was 43%, which came down to 24% minimum. And after starting the steroid-free protocol, it was 1.5% 1 year and 6% 12 years, mostly because of weight gain. So diabetes less, high blood pressure less, cardiovascular benefits more, long-term patient graft survival.
Right. Dr. Bansal?
Yeah, so Dr. Pathak, very, very good result. 2 questions I want to ask. One is what is the proteinuria in your cohort, in your patient, proteinuria and the chronic rejection in your patient? Have you done any DSAs in your patient to find out?
I don't do any DSAs because what I'm going to do after DSA, the creatinine is normal. But I do both the protocol indicate biopsy, which I'm publishing again in next 1 or 2 months, based on nearly 4,900 biopsies in over 15-year period. Protocol and indicated both.
Chronic
So
rejection?
this data I'll publish. And recurrent IgA, I don't think is more. FSGS, they're the 2 main problems. FSGS, I'm using rituximab since 2007, though I did not publish data with 74% remission. Otherwise, patients do well. You are not seeing any particular problem. There is more a fear of doing this, but your metabolic profile is great, blood pressure is less. 38% patients don't require any antihypertensive drugs in this protocol.
Dr. Gulati?
Yeah, so
Many doctors have come to my center, seen my files, including Dr. R.K. Sharma. Many of these files they have seen.
Yeah.
so we experimented with the steroid-free protocol in children. We have found higher chronic antibody-mediated rejection. So we have changed our strategy. We at 1 year we get them onto alternative steroids, and you get excellent growth rate. This protocol I adapted from my tenure at Royal Children's Melbourne, which is well published. So one of the ways to get around, at least in children, if you want to optimize growth, is that at 1 year, if they had an event-free, just get on to 5 milligram alternate day, and they get very good growth.
Any other protagonist of steroid free? Okay, thank you so much. I think we've had a wonderful session of more than an hour. We are running about 15 minutes behind schedule, which is so unusual for the Goa conclave. And thank you so much. I think we had a wonderful discussion, which compensated for the delay in this program.